Our first speaker is going to be Kim WILTROUT, who's going to talk to us about SYNGAP, Genotype, and Phenotypes. And Kim is a very promising junior researcher from Boston Children's.
All right, thank you so much, Ingo. As he mentioned, I am from Boston Children's Hospital. I'm an instructor. Oops, it's a sensitive button. An instructor at Boston Children's Hospital, part of the neurogenetics, epilepsy genetics program there. It's my pleasure to lead off this session today, and thank you for inviting me. I have consulted for Stoke Therapeutics. So I'm going to start with a brief background of clinical associations with SYNGAP1, and then review comprehensive phenotype analysis of SYNGAP1 related disorder from the Citizen data platform, and then following that, review the genotype phenotype analysis. Looking back at where we've been with SYNGAP1, the first associations were actually in 2009, so get a little closer. Not so very long ago, and it was first associated with non-syndromic intellectual disability, followed shortly thereafter by autism spectrum disorder, and then in 2013 as a developmental and epileptic encephalopathy. By 2019, over 200 patients were reported in the literature, and we know now that there are many more patients than that. Also in 2019, Professor Scheffer's paper describing in more detail the epilepsy was also reported. Our study then aimed to take that, what's known further, and look at more comprehensive phenotyping, particularly of the neurologic features, using data from 147 patients with likely pathogenic or pathogenic SYNGAP1 variants that were obtained from the Citizen SYNGAP1 data platform. The classifications, likely pathogenic and pathogenic, were provided by first the labs that had done the clinical testing, and then reviewed by those at Citizen, and then ultimately also reviewed by us for agreement with the classification. Then we used this data to identify key features of SYNGAP1 related disorder that could be looked at further as potential outcomes that would be relevant to clinical trials. And we also wanted to demonstrate the utility of using this method of digital data collection for phenotyping analysis. A word now, as Ingo mentioned, about some of the benefits, limitations of digital data collection as compared to the sort of prospective natural history studies. Some of the benefits are that it can improve access. You don't have to physically be located in where the study is taking place. On the other hand, the limitation of this is that there's no direct patient contact to verify symptoms and onset or to do more detailed interviewing, exams, etc. Another benefit is that you can utilize data that already exists in the medical record, and this can increase efficiency. But the limitation, on the other hand, with this is that the data then depends on what's actually available in the medical record. So the earliest data documented used as age of onset of the diagnosis and proxy as of age of onset. And the last date of entry is then used as the stop date for the symptom or medication. It also assumes that the patients with the diagnosis fit the diagnostic criteria. Of course, you can sort of check this in the data that's available. So again, going back to our study, our cohort of 147 individuals, the median age of SYNGAP1 related disorder diagnosis with genetic testing was 4 years, with a range of most being between 2 to 7 years. And the median current age of individuals in the cohort was 8 years, with a range of most being between 5 and 13 years. And the youngest individual was 30 months. This is important to keep in mind when I talk about some of the timing of the onset of some of the symptoms. And the phenotypic features then of this cohort with SYNGAP1 related disorder, you can see 100% had either diagnoses of global developmental delay or intellectual disability. And then the next most common feature is epilepsy, with 83% having epilepsy, followed then by behavioral problems, autistic features, sleep problems, feeding problems. Gait abnormality is typically more of an uncoordinated gait, which is closely related to the ataxia you see there, with 21%, a sort of coordination problem. And then also 24% had anxiety disorders, 24% had sensory problems, and then rounding out some of the symptoms were strabismus, cerebral palsy diagnoses, and ADHD. And looking then more specifically at what we included in the sensory problems or the diagnoses that were included there, 18 individuals had high pain tolerance, 18 had sensory processing disorder, and 5 had diagnoses of both. One of the questions that I was asked last year when I presented was there an association between behavioral problems and those with autistic traits or diagnoses of autism? This is a reasonable question to ask, but there actually was no significant association between behavioral problems and those with autism. But rather, there were higher rates of behavioral problems in those who had anxiety and in those who had sleep problems. And I think this is helpful to keep in mind when, as a clinician, you're thinking about how you may be helping with behavioral problems. You could also target some of the anxiety and sleep to potentially help with behavior. And then diagnoses included in feeding problems, most of them were nonspecific, feeding difficulty or problem, but dysphagia, oral aversion, failure to thrive, and slow weight gain were also listed in that order and included as feeding problems. Looking a little bit more at the SYNGAP1 related epilepsy, you see here the frequency of the different types of seizures that individuals had. A minority had epileptic spasms, and the majority of individuals had a generalized epilepsy with atonic seizures, or the most frequent was absence or atypical absence seizures. There are a number of case reports and case series that detail individuals with reflex seizures, and what I mean by that are seizures that tend to occur with the eyelid myoclonia, the fast eyelid fluttering, and seem to be provoked by eating. In this study, that was reported in just over 30 individuals, so it was not the most frequent seizure type. But again, this depends on it being reported in the notes in the medical record. And then looking at the different epilepsy syndromes using the ILE criteria and how they fit within this syndrome, this was, Professor Sheffer had mentioned this in our very first talk of the day, that those with SYNGAP1 do fit in the criteria for some of the epilepsy syndromes. The most frequent, though, was a developmental epileptic encephalopathy that really we couldn't necessarily classify within one of these syndromes. And then of the most frequent that we could classify were either epilepsy with myoclonic atonic seizures or a Lennox-Gastaut syndrome. From the details provided, it was, for some, there was a bit of an overlap, so I included both within this category. And then this is followed by epilepsy with eyelid myoclonia, and then those who have intellectual disability or global developmental delay and do not have epilepsy, and then the least frequent was infantile epileptic spasm syndrome. And then looking at the timeline of when the onset of these different features occur, we see for epilepsy, there is, most of these individuals start to have seizures between the ages of 2 and 6 years old, so that by 3 years old, half of the cohort is diagnosed with epilepsy, and by 6 years old, you reach over 80% diagnosed with epilepsy. Before the age of 2, you really don't see as frequent diagnosis of epilepsy, as shown here by this cumulative incidence curve. And then thinking about the anti-seizure medications that were reported being taken by these individuals, I show here this table, and it's important to keep in mind as you're looking at it that this is not data from any sort of randomized control trial. These are just medications that were being reported as having been initiated in these individuals and then currently taken or continued up until the time point of the end of the data collection in this cohort. And you can see here that the medications, they make sense based on the seizure types primarily being generalized seizures. You see a higher occurrence of clobazam, valproate, lamotrigine being used. These are medications that are commonly used for generalized seizures, and those are also the medications that were the most continued. You can see levetiracetam was the most initiated medication there at the top of the table, but it actually less individuals were taking it currently. It dropped from being initiated in 48% down to 21%. The data don't necessarily give us an answer as to why, but it's perhaps that we know it can worsen behavioral or irritability in children, so perhaps it was that it wasn't tolerated, or it also could have been that it was ineffective in controlling seizures. We just can't tell from this data collection, but there is that suggestion there. And again, looking at the timeline now for the other features of SYNGAP1 related disorder, I had already mentioned epilepsy with the onset of seizures and the diagnosis of epilepsy being at about 2 years old, and most individuals having that diagnosis between 2 and 6 years old. Comparing that then with autism, we see similarly that the autistic traits and diagnosis of autism really starts to have onset around 2 years old. This makes sense with current practice in the United States where this data was primarily collected, being that we really start to test for autism at 2 years old. And then you can also see with behavioral problems, the onset being reported at 24 months or about 2 years old, and the predominant curve really being up until about 84 months. And then for ataxia and gait problems, again, you start to see that these are being diagnosed between about a year, 1 and 2 years. And then there's another bump in the curve as individuals reach adolescence and adulthood. And then looking at when these individuals achieve developmental milestones, the individuals predominantly did eventually gain the ability to walk. 87% of patients had learned to walk at a median age of 20 months, so there is a bit of delay compared to when typical development is expected by at least 18 months of age. And then compare that to language development, where you see much more of a delay. 58% had achieved a vocabulary of at least one word, and the median age of those who had achieved speaking one word was at 2 years. And then for those who achieved speaking in phrases, only 28% of the entire cohort had achieved that, and the median age was much later at 4.5 years, only including those who were able to eventually speak in phrases in that analysis. So then putting this all together and looking at any relationships or predictions that could be made based on genotype and what the phenotype may look like, I want to first just talk about some of the variants, and this was a focus of earlier sessions, but these are the recurrent variants in this cohort, and you can see most of these are protein truncating variants. This makes sense with what we know about this disorder being a sort of loss associated with loss of function in the predominant variant types. And then again, similar to what was heard earlier today, the likely pathogenic missense variants were really all found within the domains, the pH domain C2 and RAS-GAP domains. And then looking at the phenotype based on the location in those domains, we did see, looking at this table, that epilepsy did seem to be, there was a trend toward epilepsy being less frequent in those within the SH3, and that should be motif, actually, SH3 motif. But otherwise, there were no significant differences in the clinical features based on the variant locations in the different domains. You can see between the domains where majority of the variants are located, PHC2 and the RAS-GAP, there wasn't a difference. And then looking at phenotype based on the variant, so between the truncating missense, intronic, and the deletions, there was no significant difference found in the different symptoms except for ADHD, and that had very low numbers in all of the different categories. And then looking at phenotype based on the location of the variant, that in those variants that were predicted to cause a nonsense-mediated decay, we did see an increased percentage of the ability to speak in phrases in those who had variants within exons 1 through 4. I can't point with this. You can see that in this table here. And we had looked at that in particular because this had been raised in earlier papers, that it seemed that those individuals who had variants in those early exons seem to have more mild intellectual disability or more ability to speak in phrases. So this was in keeping with what had been previously suggested. But otherwise, there was no difference between the different features. So in summary, we've demonstrated that there is some usefulness in analyzing data from a digital data platform retrospective approach. we can use this comprehensive phenotype analysis to identify some of the key features to focus on in more prospective studies, such as the intellectual disability, a predominantly generalized epilepsy with onset between ages of 2 and 6 years, autistic traits, behavioral and sleep problems. And we saw that behavioral problems seem to have an association with anxiety and disordered sleep. And we also looked at genotype and phenotype analyses where missense variants seem to be located within the domains, as was talked about earlier today. And there was a trend toward epilepsy being less frequent in variants within the SH motif, and a trend toward increased percentage of ability to speak in phrases in those with variants within exons 1 through 4. And with that, I will acknowledge my mentors on this project, Dr. Paduri and Dr. April Levin at Boston Children's Hospital. You'll hear from her EEG studies later this afternoon, so I encourage you to stick around for her last talk of the day. And then Dr. Ingo Hublich, who is leading or moderating this session, who is will be mentoring on continuations of this project, as well as the rest of the Boston Children's Hospital epilepsy genetics program, and I have our funding listed there at the end.